Welcome to the deep dive. Today, we're zeroing in on a really critical topic for anyone in medicine, ventricular tachycardia, VT.
Yeah, VT, definitely need to know stuff.
Think of this as your kind of express lane to understanding VT. We're pulling out the essential facts from our notes so you can, learn it efficiently and remember what really matters.
Exactly. Cut through the noise.
So our mission for the next few minutes, a clear, concise, and hopefully memorable rundown of VT, what it is, the different kinds, what causes it, the risks.
The pathophysiology, how we spot it, and crucially, how we manage it.
Right. Ready? Let's dive in.
Okay, let's start with the basics, the definition. Ventricular tachycardia is essentially a fast heart rhythm. We're talking over 100 beats per minute, often like way faster.
And it starts where?
It originates down in the ventricles, the heart's main pumping chambers. And the key thing you'll spot on an ECG, a wide QRS complex, usually over 120 milliseconds.
Wide and fast from the ventricles.
Got it. And our main goals, when we see VT, are firstly, get the heart back into a normal rhythm if possible.
And stop bad things happening.
Precisely. Prevent serious complications.
Okay, so what about the main types, which we keep in mind?
Well, we mainly talk about monomorphic versus polymorphic VT.
Mono versus poly.
Right, think mono for one. In monomorphic VT, all the beats look pretty much the same on the ECG. They're coming from just one irritable spot in the ventricle.
Consistent shape.
Exactly. Then polymorphic, poly meaning many, the beats change shape and size from one to the next. It suggests a more chaotic electrical source or multiple sources.
More disorganized looking?
And we also classify it by how long it lasts. Sustained VT means it goes on for more than 30 seconds or causes collapse.
Okay.
Non-sustained VT stops by itself in under 30 seconds.
And sustained is generally more worrying.
Definitely. Sustained VT is often a big red flag for underlying heart issues, things like a previous heart attack, cardiomyopathy, myocarditis.
Structural problems.
Yeah, and a high yield point for exams. Monomorphic VT is actually the most common type of sustained VT.
Good to know.
Oh, and also be aware some drugs can actually trigger VT, especially certain antiarrhythmics, the class 1s like flecainide, disopyramide. It's a bit paradoxical.
Right, the pro-arrhythmic effect. Okay, so one bad spot versus an electrical storm, kind of. What about those other specific types you hear about, like fascicular?
Ah, yes. Fascicular tachycardia. It's less common. It comes from a specific part of the conduction system in the left ventricle, a fascicle.
Okay.
A key thing here, often for exams, is that it can happen in people without major structural heart disease.
Oh, interesting.
Yeah. And the ECG often shows a narrower QRS than typical VT, often with a right bundle branch block pattern. Maybe think fascicular, fine QRS, funny origin.
Fine QRS, funny origin, got it. And RVOT.
Right, ventricular outflow tract tachycardia starts, as the name suggests, in the RVOT.
Makes sense.
The ECG typically gives you right axis deviation and a left bundle branch block morphology. Maybe RVOT, right axis, left block.
RVOT, right axis, left block. Okay.
And we should definitely mention torsades of points quickly. That's a specific type of polymorphic VT linked to a long QT interval. Huge exam link there.
Long QT leads to torsades.
Yep.
And then there's just general polymorphic VT. Looks similar to torsades sometimes, but can happen in other contexts, like during a heart attack. It's nasty stuff, high risk of degrading into VF.
Ventricular fibrillation.
Right.
Very dangerous. Okay, so those are the types. What about the root causes, the etiology?
Well, the big players are structural heart disease again, cardiomyopathy, coronary artery disease are top of the list. Then electrolyte imbalances. Think low potassium, hypokalemia, and low magnesium, hypomagnesemia. Those are really key.
Always check the electrolytes.
Always. And then you've got drug toxicity and also some inherited conditions, genetic channelopathies like long QT syndrome or Brugada syndrome.
So structure, electrolytes, drugs, genes.
That covers the main areas, yeah.
And who's most at risk? What are the risk factors we look out for?
Okay, generally speaking, a history of any ventricular arrhythmias before is a big one.
Makes sense. Then structural heart disease again, heart failure, a previous MI, those electrolyte issues, potassium, magnesium, also low calcium, hypocalcemia.
It's also good too.
Yeah. Drug toxicity, a family history, and even stimulants like caffeine or, cocaine.
Wow, okay.
For sustained VT specifically, we often think about it happening later after a heart attack, especially if there's a left ventricular aneurysm.
Like a scar tissue circuit.
Exactly. Also, various cardiomyopathies, hypertrophic, alcoholic, a condition called right ventricular dysplasia after myocarditis, and again, those class 1 antiarrhythmics we mentioned.
So a history of heart trouble is a massive theme here.
It really is. Either pre-existing damage or some acute insult.
So what's actually going electrically haywire in the heart during VT?
Mm.
The pathophysiology.
So VT happens because you get these abnormal electrical impulses firing off super rapidly in the ventricles.
Okay.
The mechanisms are usually one of three things. Re-entry circuits, that's like the electrical signal getting stuck in a loop going round and round.
Firing constantly.
Yeah. Or increased automaticity, where some ventricular cells just decide to start firing off way too fast on their own.
Like rogue pacemaker?
Kind of. Or triggered activity, where one beat abnormally triggers a whole cascade of rapid beats.
Right.
Whichever way it happens, the result is this rapid but disorganized ventricular rhythm, and that really messes up the heart's ability to pump blood effectively.
It's beating fast, but not actually pumping well.
Exactly.
Yeah.
Leading to potential cardiovascular compromise, even collapse. It's like the main pumps are going into overdrive, but totally uncoordinated. Useless, really.
Uncoordinated overdrive. Good visual. Now, this is crucial if we see a patient, fast heart rate, wide complexes on the monitor.
Mm-hmm.
How do we know it's VT and not something else that looks like it, the differential diagnosis?
Yeah, this is super important for safe management. The big mimic is supraventricular tachycardia, SVT, but with aberrant conduction, meaning the fast supraventricular rhythm travels down abnormally, making the QRS look wide.
So SVT can look like VT sometimes.
It absolutely can. You also need to consider things like atrial fibrillation with a really rapid ventricular response, or even just sinus tachycardia if the patient has a pre-existing bundle branch block making the QRS wide anyway.
Okay.
And obviously, you need to differentiate it from the even more chaotic ventricular fibrillation, VF. Plus, think about conditions causing similar symptoms like a massive MI or acute heart failure, basically any broad complex tachycardia.
Should make you think VT first.
Exactly. That's the golden rule for exams and practice. If you're not sure, or especially if the patient is unstable, low BP, confused, whatever you treat it as VT.
Why is that so critical?
Because some treatments for SVT, like verapamil, for instance, can be disastrous, even fatal if given to someone who actually has VT.
Okay, wow. So wide and fast, treat as VT first until proven otherwise.
That's the mantra. Better safe than sorry.
Got it. What about here in the UK? How common is VT? Who gets it?
Well, exact prevalence figures are a bit hard to nail down, but we know it's definitely more common in people with underlying heart disease.
Like coronary artery disease.
Yeah, especially ischemic heart disease and cardiomyopathy. You also see it often alongside VF during witnessed cardiac arrests out in public.
Right.
Coronary artery disease is probably the most typical underlying cause you'll find.
And age group.
It tends to peak in middle-aged and older adults, usually those who already have some structural heart disease. So yeah, think middle-aged or older with a known heart problem.
Okay, links back to those risk factors. So how might a patient actually present? What symptoms and signs are we looking for?
It can be quite variable. Some might just feel their heart racing or fluttering palpitations. Others get dizzy, lightheaded.
Near syncope?
Or full syncope, yeah, fainting. Some might get chest pain, particularly if it's severe or causing ischemia.
And it often happens in people we know have heart issues already.
Often, yes. Or they might present with signs that their circulation is compromised, what we call hemodynamic instability.
What does that look like?
That's things like shortness of breath, maybe crackles at the lung bases on listening.
Fluid backup.
Raised JVP in the neck, low blood pressure, hypotension, and changes in mental state. They might be anxious, agitated, or really lethargic, even comatose in the worst case.
Serious signs.
Definitely. If they're unstable, that's an emergency. If they're awake, talking, blood pressure okay, they're likely stable VT, which is still serious but buys you a bit more time.
Right. So if we suspect VT based on presentation or rhythm strip, what are the key tests we do in the UK?
The absolute cornerstone is the 12-lead ECG. That's number one.
What are we looking for specifically?
You're looking for that heart rate over 100, usually it's 150, 200 range. The wide QRS complexes over 120 milliseconds. Other clues that point strongly towards VT include AV dissociation, where the atria and ventricles are beating independently. You see P waves marching through the QRS complexes.
Wow.
And things called fusion beats or capture beats, which are signs the ventricles are being controlled from down below. But occasionally a sinus beat gets through.
Tricky things to spot sometimes.
They can be. And remember, sometimes if there's retrograde conduction back up to the atria, it can mimic SVT with aberrancy. So the ECG needs careful interpretation.
Okay, ECG first. What else?
Definitely check electrolytes. Potassium, magnesium, and calcium are vital. Low levels, as we said, can trigger VT or torsades.
Right. K, mag, calc.
Yep. If you suspect drug toxicity, check relevant drug levels, like digoxin maybe. We'd also usually check for myocardial ischemia troponin levels.
Looking for a concurrent heart attack.
Exactly. And maybe a chest x-ray, especially if you're worried about heart failure or other lung problems.
So ECG first, then bloods for electrolytes, troponin, maybe drugs, and consider imaging.
That's the initial workup.
Yeah.
ECG first, then look for the cause.
Okay, now the really crucial bit. How do we manage VT?
Right. Management really hinges on one question first. Is the patient stable or unstable?
Stability dictates the approach.
Absolutely. If they're hemodynamically unstable,
I
poor perfusion, low BP, altered mental state, the answer is immediate electrical cardioversion. Shock them.
Synchronized shock.
Yes, synchronized cardioversion. Get them back into a safer rhythm quickly.
Yeah, if they are stable, blood pressure, okay, alert.
If they're stable, we generally start with antiarrhythmic drugs. Amiodarone is often the go-to first-line drug. Ideally given through a central line if possible, but peripheral is okay initially.
Okay, amiodarone, alternatives.
Lidocaine is another option, though you use it cautiously if they have really poor left ventricular function. Perkinamide is sometimes used too.
What should we avoid?
The big one to avoid in wide complex tachycardia, especially if you think it's VT, is verapamil, calcium channel blocker. Very dangerous in VT.
Avoid verapamil. Got it.
Yeah.
What about long-term, or if it keeps happening?
For recurrent VT, or in high-risk patients, we start thinking about more definitive treatments. Catheter ablation is one.
Burning the spot?
Essentially, yes. Using catheters to find the irritable focus or reentry circuit and eliminate it. Or an implantable cardioverter defibrillator, an ICD.
The internal defibrillator.
Exactly. A device that monitors the rhythm and delivers a shock internally if dangerous VT or VF occurs. And of course, always treat the underlying cause. Fix electrolytes, manage heart failure, consider revascularization if it's ischemia.
Makes sense. Address the root problem.
Yeah. If drugs aren't working well for stable VT, sometimes an electrophysiology study, or EPS, is done to really map out the problem, and guide therapy may be ablation.
Okay, and those algorithms. Pulseless VT.
Pulseless VT is treated exactly the same as VF. Follow the standard cardiac arrest, VF protocols, high-quality CPR, defibrillation, drugs like adrenaline, amiodarone.
And unstable VT.
Unstable VT follows the tachycardia algorithm. Urgent synchronized cardioversion is the key. Start with a lower energy maybe, but shock them. Advanced life support continues alongside.
Stable VT again.
Stable VT, as we said, drugs like amiodarone or lidocaine. Cardioversion is still an option if drugs fail or they deteriorate. Ablation is a longer-term consideration. For refractory VT, maybe an amiodarone infusion.
And who gets an ICD?
Yeah.
Based on NICE guidelines.
Right. NICE guidance suggests ICDs for people who've survived a serious ventricular arrhythmia.
Secondary prevention.
Yes. Or for primary prevention in people with certain high-risk familial conditions, or those with heart failure and a significantly reduced ejection fraction, typically LVEF, less than or equal to 35%, despite optimal medical therapy.
Okay. And sometimes they get CRT too.
Yeah, if they meet criteria for cardiac resynchronization therapy as well, they might get a combined CRT-D device.
Right. So shock for unstable, drugs ablation ICD for stable and long-term. What's the outlook? The prognosis?
It really varies quite a bit. Depends heavily on the underlying cause, how much structural heart disease there is, and how effective the treatment is.
Can be serious, though.
Oh, absolutely. VT can be life-threatening. It can degenerate into VF and cause sudden cardiac death. That's the big fear.
But treatment helps?
Definitely. Prompt recognition, getting the right management quickly, and controlling those underlying risk factors can significantly improve the prognosis, but complications can still happen. Well, recurrent VT, obviously. Worsening heart failure, because the VT itself can impair heart function over time. Cardiogenic shock if it's severe. And as mentioned, the ultimate risk is sudden cardiac death if it deteriorates into VF.
So early recognition, swift action are absolutely key.
Couldn't agree more. They're critical.
Well, that was a pretty rapid but hopefully really high-yield deep dive into ventricular tachycardia. We've hit the definition, types, causes, risks, what's going wrong, diagnosis, management.
Yeah, covered all the essentials. Knowing this stuff about VT is just crucial in day-to-day clinical practice, and definitely for exams.
Absolutely. And for those of you prepping for your MSRA exams, looking for more targeted revision tools, don't forget to check out passthemsra.com.
And freemsra.com as well. Both excellent resources to help nail down this kind of information.
Definitely worth a look. Thanks, everyone, for joining us on this deep dive.